All right, you want to go? You can.
Sorry, I was muted.
Okay.
Can you guys hear me now?
Yes, I can hear you.
Okay, yeah, so this is a 72-year-old female. She noticed declining vision in both eyes as well as many floaters. There has been gradual loss of vision in both eyes over several months. She was diagnosed with diabetes around 2000. Patient is recently bruising for a few weeks on her legs. She has diabetes and high cholesterol. She takes metformin, some other medications, cetirizine, nortriptyline, propranolol, Ozempic that was discontinued a week ago. And her vision's 2100, best corrected 2080 in the right, left eye, best corrected 2080, J16 and J10 respectively, with pressures at 11 and 10. And this is the first picture.
Clear from this photo of the right eye. Vitreous appears clear, nerve appears tilted. Does appear pink and sharp at borders. Vessels appear a little tortuous, with some attenuation as well in some areas. I'm only seeing one set of vessels. And then there's the inferotemporal area. There is looks like some hard to tell if it's infraretinal or periretinal heme. Some like dot plots and hemorrhages in the inferotemporal area.
Yeah, there's just, yeah, exactly, there's some hemorrhages. There looks like there's like a sclerotic vessel here too. It's like kind of white, but the other picture is better.
Dot plots as well, maybe along the other arteries.
Yeah, I think this one's a little bit clearer. The other one's kind of blurry, but
If I'm sort of wider view. Is there more hemorrhages over there?
yeah, I think it might be. Let me see if I can mag it up here. I don't know. I've never tried this. Okay.
Oh yeah, there we go. Scattered dot plots and
In some of those plaque hemorrhages, there's any way you would describe? He was kind of pointing to this one.
Yeah, there's like a little
is that like
white spot there.
It's a little Rothish, isn't it?
Yeah.
Anyway, just that one, and maybe the other ones are hard to sell, but that one looks a little.
Yeah, this one maybe, but.
Other fundus photo, left eye, vitreous clear, tortuous vessels, multiple like dot plot hemorrhages along the arcades, kind of scattered smaller ones in the macula as well, maybe. Maybe some of them appear a little Rothish, the infranasal one.
There's a couple that might be. I mean, there's one over here
as well.
The other thing is the veins are pretty dilated, huh? Almost like this would be plus disease if it was a ROPD, which is not. And how long was the vision loss over? I can't remember. Sorry.
Let's see.
She's a gradual, several
gradual,
months.
yeah.
And easier to appreciate the rock spots in the other one, but so OCT scan, zoom through the right eye, hazy media. It looks like some intraretinal edema, kind of right over the fovea. I assume right over the fovea. With possible trace subretinal, but no, I don't think that's subretinal.
No, it's subretinal, which is a big deal for patients. Usually a little subretinal fluid can be very symptomatic.
Yeah, I think you got that one pretty good.
Left eye.
Actually, this might still be.
No, it's left.
This is well, I think this is the superior inferior. I think.
Did you see the nerve?
Oh no, it is left eye. Yeah.
Left eye, intraretinal edema right over the fovea again. Maybe a touch of subretinal fluid right under there too. Good.
So, and I always put these in the chart, so the thickness are 507 in the right, 577 in the left. Do you know what those numbers are supposed to be about?
300, 200?
Yeah, under 300 usually. For a lot of our studies, under, 270, 280, 300 is a little bit high. 577 is way too high.
FA of the right eye. So looks like the vessels. You can see some, it's like a little bit of. There's some leakage, or like there's some MAs I can see earlier on along the superior arcade there. Some parafoveal hyperintensity maybe.
Yeah, hyperfluorescence. And you can't call leakage on one image. Yeah. So you can say it's hyperfluorescence, kind of patchy, old funny looking microaneurysms.
And so increased parafoveal hyperfluorescence.
Yeah, and then they basically just I think showing where the hemorrhages were on the.
Yeah, and you're looking, the sweeps on a diabetic are looking for non-perfusion and neovascularization. So there's really not, I mean, even though there's irregular hyperfluorescence, that's not really non-perfusion probably. And there's definitely not neovascularization.
Areas of like hyperfluorescence with the central area of hypofluorescence and kind of patchiness throughout the core. Maybe there's a small area of hypofluorescence there.
That's probably that hemorrhage.
Oh, but
If there was a hemorrhage there, it's probably blocking.
Yeah, I think this is just a fovea here as well.
Yeah, and then down in the middle. And so is that leaking? Now that you've seen a couple pictures, is it leaking or staining? When you look at the early and the late.
This is like an earlier one, it's a later one.
can you do that one more
Go
time?
really early, go like super early. There, so that's early and that's late.
Can you do that one more time? Okay, looks more me staining because it appears to kind of stay in the same area maybe. Leaking.
Yeah, it's smudging out some, it's kind of leaking. There is, what you're thinking of in the center of the fovea. So we know there's cysts there, right, in the center.
Right.
So those are filling. So that would be pooling. But there's also just diffuse leaking. Everything's just kind of leaking everywhere.
I guess there's the left eye here.
So what phase is that?
The arterial phase.
Good, nice.
Some MAs, you can see some spots of hypofluorescence from the blocking. I think appreciate some of this leaking on the vessels, some hyperfluorescent spots. Those are MAs, some small spots that block the hypofluorescence. That's the blocking.
Yeah, we got it.
Nice.
It's like a very late stage. Here.
Diffuse leakage at central hypofluorescent area surrounded by the hyperfluorescent.
And one way to cheat is if you have the OCT and there's a edema, it's leaking somewhere. You gotta know it, but it's nice to get it from the fluorescein independently.
The disc is good. It's kind of diffuse.
Like if you had an OCT with edema and then a fluorescein that was normal, not like that, then you get into that differential of non-leakage macular edema, which we're not in.
So yeah, that was the last of the pictures. Do you have a differential that's kind of top of your mind?
Well, the Roth spots could be related to like an anemic, I don't know what it's called.
Anemic retinopathy.
Anemic retinopathy.
She was bruising. When she said, I asked her if anything else, she said she was bruising. Then she started taking her clothes off to show me. And I'm like, no, that's okay. I was just wondering if you were bruising. I think and so she pulled her leg up and showed me a bruise, and then she was gonna show me the rest of them. And I was like, I'm just gonna
I
get some,
believe you.
I don't need that.
So anemic retinopathy, diabetic retinopathy with associated macular edema. A uveitis, potentially there's a lot of leakage, but there's no deep leakage to the disc.
No, uveitis.
Posterior uveitis.
Yeah,
Or-
that's pretty good. I got these ones, but yeah.
Yeah, and also in a history of diabetes, 72-year-old patient, so with risk of like cardiovascular event, we should rule out also ocular ischemic syndrome like OIS, and also in the ultrasound in this patient would be very important just to make sure everything is normal.
All right. Yeah, so we got they got CBC and showed really high neutrophils and white blood cells.
Yeah, look at the white cloud on top.
Yeah.
See it on the very top of the picture.
Yeah.
260.
There's a differential here pretty high. Yeah.
They called us on the weekend. It's the first time we ever had that on a white count. It's like, we're just calling with the white count. I was like, oh, great. So I called the patient, her husband. I said, where are you like right now? They were out of town. They were at a fair or something, and I said, well, you just need to go to the hospital. And I said, now we'll make sure they went to a good hospital. We have some bad hospitals. So it's like, so I got them to go to a good hospital.
So yeah, she was diagnosed with chronic myeloid leukemia. She was treated with avastin for the DME, and she was dry after an injection. Visual acuity at 1 month was 20/50 in both eyes, and I guess the plan was to treat for 3 treatments and stop. So this is kind of the progression there. Dried out pretty good with some Avastin.
Yeah, because I wasn't sure if it was the leukemia or the anemia, or the leukemia or the diabetes. So I treated for a while, stopped. Actually, I just saw her yesterday. Yeah, yesterday, and I needed to restart her treatment. Because I thought she might get off the hook if it was just the leukemia and she got that treated, but actually some of it was diabetic. So just a smidge worse.
So we'll talk about leukemic retinopathy. It's a hematologic malignancies that affect lymphoid or myeloid lineage cells. Generally, you get some, pretty constitutional symptoms: weight loss, fatigue, fever. Depending on the platelet count, she may also present with bruising, which is what she did. There's 5.4 cases of leukemia per 100,000 globally as of 2020. Ocular symptoms affecting any structure observed in up to 90% of patients, and 40% a diagnosis of leukemia have ocular symptoms. 30-50% of leukemia patients have retinal manifestation, more in acute compared with chronic cases. And histologic studies show uveal tract to be more commonly affected, possibly serving as a sanctuary site for the cells. For the pathophysiology, you can get primary direct infiltration of ocular structures. For indirect or secondary etiologies, like a hematologic abnormality such as intraretinal hemorrhage or convulse spot, CNS involvement through optic nerve head infiltration, infection, or it can be like chemotherapy-related complication causing the leukemic retinopathy. Vitreous involvement is quite rare and usually results from retinal hemorrhage. In cases affecting the retina, you have increased number of circulating platelets and white blood cells, leading to increased blood viscosity. Stagnation can cause ischemia and capillary closure, resulting in proliferative retinopathy. So it could be a combination with this patient with diabetes as well. In terms of the signs and symptoms, again, they're going to present with vision loss, maybe floaters, visual field defects. This is like a more frank, classic picture that you find in a textbook. For the retinal findings, dilated tortuous veins, which she had, retinal hemorrhages at any level, pseudo-Roth spots, we'll discuss that later, convulse spots, perivascular leukemic infiltrates, which are usually gray. There's also other leukemic infiltrates, which are more rare, that are yellow/white. Vascular occlusions can occur, such as bilateral CRVO, get microaneurysms, neovascularization, retinal detachments, and infection can occur. For the choroid, you can detect that on ultrasound. You can also have a CRS-RD overlying that. The iris can be diffusely thickened with loss of the crypts, and you can have some small nodules at the iris periphery. In the AC, you can get a pseudo-hypopion, which may give rise to a secondary glaucoma. You can get a leukemic infiltration of the optic nerve head, like right here, causing severe vision loss and edema. It's an emergency requiring immediate external beam radiation therapy and possibly intrathecal chemotherapy. The LP should be done with cytology along with urgent imaging and bone marrow evaluation at that point. So that's kind of like a board's question. That would be the treatment. And for orbital soft tissue, you can get proptosis. It's pretty rare because in the case of a granulocytic sarcoma or chloroma. In terms of the Roth spots, these are white-centered hemorrhages. They contain aggregates of white blood cells, platelets, fibrins, and microorganisms possibly. That's why originally it was associated with endocarditis with those microorganisms. Otherwise, it's called a pseudo-Roth spot. That can be caused by anemia, hyperviscosity, or thrombocytopenia. And the centers may contain neoplastic cells. I think everyone just calls them Roth. I don't think anyone calls them pseudo-Roth spots.
Yes, the genetics is wrong.
Yeah. In terms of the diagnosis, labs are important. CBC with differential. In the case of CML, which this patient had, there's going to be leukocytosis with left shift and thrombocytosis. In ALL, it's neutropenia. Any level of leukocytes, anemia, or thrombocytopenia can occur. AML will have pancytopenia. And in CLL, it's going to be lymphocytosis and pancytopenia. Peripheral blood smear will show blast cells. Bone marrow biopsy can show blast cells. Flow cytometry and chromosomal testing can also be used as necessary. Vitrectomy can be done if necessary. And in terms of imaging, it's like what was done, OCT-FA. The treatment-wise, you want to treat the underlying cause, so systemic chemo, radiotherapy is optional unless, again, there's acute vision loss associated with optic nerve infiltration. For ALL, there's some chemo of vincristine, pred, and L-asparagine. And AML, you're going to use daunorubicin, cytarabine, and thiaguanine. CML, which this patient has, you'd want to treat with busulfan and hydroxyurea. And it may require an allogenic bone marrow transplant. For adjunctive therapy, intravitreal steroid, anti-VEGF, or methotrexate can be used. The retinopathy portends a poor 5-year survival. It's about 21%. If there is no retinal involvement, it's around 45%. And that's it.
Very nice. Thank you. That's very good.